Good morning, and today I'm going to be explaining to you the complex extraction procedure and the difference between a complex extraction procedure and the simple extraction procedure is that a simple extraction can be done by a general dentist, just with no, not only with the pair of forceps but with forceps, and then in a complex extraction procedure, usually the general dentist will refer you to an oral surgeon because the oral surgeon has 4 to 6 extra years of extra schooling after dental school, because there's different types of instruments that we use that they would use compared to a general dentist. And if the patient is at high risk, and there's certain things that the general dentist is able to do, but that an oral surgeon has just a lot more information and training, to do like this procedure. And then complex procedure, there's just a lot more to it. Like I said, does the patient have extra any health like conditions? Is the location of the tooth like way in the back where it's hard to access? Do they have a root tip stuck in their down in their socket? And so there's a lot of different indications for a complex surgery. And we're going to start by reviewing our patient's health history. Do they have any contraindications to our local anesthetic that the doctor will administer? Are they taking any blood thinners, which is really bad? And then they are going to be either under nitrous oxide, which is just laughing gas, or intravenous sedation, which is still conscious sedation, where the patient will be able to talk to the doctor, maybe not in like complete sentences, but would be able to communicate with the doctor, and they probably won't remember at all. And then there's also general anesthesia that usually is the safest to do in a hospital environment. And usually the hospitals will let oral surgeons use their rooms, especially because their nurses have a lot, more practice on paying attention to the patient and their vital signs while they're under. And it's very important that the oral surgeon themselves have that extra training and that extra schooling for that as well. And so we're going to make sure that the patient is not in risk of anything. Explain the procedure to them. Do they have any questions, any concerns? And when everything's clear, we can go ahead and have them sign the consent form. And once the consent form is signed, we can go ahead and start taking their blood pressure. Normal blood pressures less than 120/80, so less than 120 and then less than 80. And when we know that their blood pressure is normal, everything's good, we can go ahead and tell them the post-operative instructions that will be given to them verbally and written out. And we'll be giving these to the patient before the procedure and then after the procedure. And then if they have someone caring for them, for after, with their consent, we can go ahead and give them a copy as well. And then we will apply the topical anesthetic, and the doctor will go in with the local anesthetic, which is the cartridge, the needle, and the syringe. And then with our Explorer, the doctor will go in and poke the gum to make sure the patient is actually numbed. And then we're going to go ahead and make sure that our doctor actually has our basic setup first. So our mouth mirror, our Explorer again, that the doctor will use to poke the gums, our cotton pliers, our air and water syringe, and then our different suctions. So our HVE, and then of course our small saliva suction. And then once the doctor administers the local anesthetic, we can go ahead and go in with the scalpel. With the doctor, I'm sorry, will go in with the scalpel and the blade to cut the tissue, to open it up if the tooth is only if the tooth is impacted. And then of course, since we're going to be using the scalpel and the handle with the blade, then that means that we are going to be the doctor will do sutures in the end, but I'll go ahead and show you the sutures later when we start explaining that more. And then we're gonna go with our periosteal elevator, and this is to start like separating your gums from the tooth if the tooth is not impacted. And we're gonna start making room for the forceps to go in. Oh, I didn't even show you. Periosteal elevator. And then if the tooth is exposed or erupted, we can go in straight to the straight elevator, but if not, we will use our high-speed handpiece and the surgical burrs to remove bone or to allow access to the tooth, or if the tooth is coming in crooked and we need to section it off, we can go ahead and go in with our high-speed handpiece with the burrs to section that off, or we can go in with our mallet and chisel, and we can use this as well. So there's the mallet. And then the chisel. And we will only use these mainly if the patient is under, because if the patient is on nitrous oxide and they're still awake, that's a lot of trauma to the tooth. That's a lot of trauma to the patient. And so only if they're under, the doctor will be thinking of using that. But if it's not, and we can go straight to the straight elevator, then we can. And this is a straight elevator, and this is to loosen the tooth from the periodontal socket. And sometimes we actually don't need to go in with forceps or the East and West Coast elevators, because sometimes the tooth can just actually pop out, like using the straight elevator. So this is a straight elevator. But if we do have to use a forceps, we will use the 150 or 151, depending on what tooth you're working off, of course. Or anterior, that's the 150, and this is the 151. And again, we want the tooth to come out all in one, but if it's not, it's okay. And then after the forceps, we'll go ahead and go in with the, if we have to, we will go in with the East and West elevators. Usually we don't have to, but these can as well. Like if the tooth is removed out of a socket, instead of using the root tip picks that I'll talk about soon, we can actually use these East and West elevators. They almost look like little flags, and then they have like that elevator handle as well. And the doctor will look at the tooth, make sure it's intact, there's not root stuck at the bottom. And then of course, like I said, if there is root in the socket, we could go in with the root tip elevator. It has a little elevator handle, or the root tip pick. And then once that's done, if the doctor does not want to promote bleeding and there's a lot of bleeding, we can go in with the surgical aspirating tip. And there's metal ones where we have to heat autoclave these, and then there's plastic ones as well. So we could just dispose of those. And then when you're done using your aspirating tip, you're going to go ahead and go in with your curette your curette, you're gonna go inside, you're gonna clean up all the gunk and the debris inside of the socket. And then after this, the doctor's gonna go ahead and smooth the alveolar ridge, which is called alveoplasty. And he's gonna go in first with his rongeur, and it's almost like nail clippers, and he like clips the ridges and trims and removes the alveolar bone. And then after that, he's gonna go in with his bone file, and to smooth the bone, they have like these little ridges that are pretty hard, and they go ahead and go in and smooth the bone. And then once that's down, the bone file looks smooth enough to suture over. The doctor will grab his sutures, and there's silk suture, and then there's absorbable suture. Silk suture, the patient will have to come in 7 to 10 days after the procedure, so we can get them stitched out. We could cut them and take them out. And then if not, there's also absorbable sutures, so we don't have to so these are the suture scissors that we're gonna cut them with. And then these are the sutures that we'll be using. So there's like the suture, and then there is the needle. And then we can either use a needle holder or a hemostat to hold the needle. This is a regular surgical needle holder, and then our hemostat. And then we're either going to use 2x2 or 4x4 gauze, depending on what your dentist wants. These are triangles, cotton rolls, but we're going to be using these right here. And we're going to fold the gauze, and we're going to place it at the extraction site. And we're going to have the patient bite onto it really hard not really hard, but enough pressure to have the bleeding stop for 30 minutes. And then extra gauze will be given to the patient just in case there's so much bleeding, that they need to change it so it's not all nasty. And then extra gauze will be given to them. And then we're going to seat the patient up slowly, repeat the postoperative instructions, give them verbal and hard copy of the instructions, and then to their caregiver person if they have one, or if they give you the consent. And then if the patient feels okay and they get up and they're not dizzy, then they can go ahead and be dismissed. And then if they have the silk sutures, they would have to come back in 7 to 10 days. Thank you.